Firstly, thank you for inviting me here. My name's Tom Poles, I'm an oncologist from London, and I was the lead investigator of the EV302 study. And I'm here in China to talk a bit about drug development and advances in urothelial cancer. The EV302 study is a big randomized phase 3 in frontline metastatic disease. It combines enfortumab vedotin, which is a Nectin-4 targeted MMAE payload antibody drug conjugate. Pembrolizumab is a PD-L1 inhibitor, and the combination, when given together, appears surprisingly active. In fact, much more active than any of the drugs we've had before. We've spent a generation trying to beat platinum-based chemotherapy, and the EV302 study did that, but not just a little bit, but did it, I think, spectacularly, with hazard ratios of 0.47 for overall survival. The most recent updated data showed median overall survival of 34 months, 30% complete response rate, a duration of response rate of 75% at 2 years for those patients who achieved a complete response. I think we also need to look at other components. Did it behave better in one subgroup or another? Was there a more effective biomarker? And the answer was actually EV-Pembro outperforms chemotherapy irrespective of the Nectin-4 biomarker, irrespective of visceral metastasis, irrespective of the choice of chemotherapy, GemCis or GemCarbo. It's also true that EV302 and the combination of EV-Pembro compared to platinum-based chemotherapy actually had a lower grade 3 or 4 adverse event rate of 50% versus 60%. That doesn't mean EV-Pembro doesn't have side effects. It does, and I'm going to talk about those in a second. What it does mean is platinum-based chemotherapy is actually pretty tough to give. And we know that. Neutropenia, hematological toxicity, nausea, fatigue, gastrointestinal disturbance, infection, bleeding, all associated with chemotherapy. Enfortumab vedotin and pembrolizumab together, when given in combination, is given until progression of disease. And therefore the management of toxicity is really important. I think observation of early skin rash and dose interruptions and dose reductions are really important. I think peripheral neuropathy that builds up with time also requires interruptions and dose reductions. I think it's also fair to say other adverse events, fatigue, transaminitis, other immune-related adverse events, all require attention. My experience, the combination, is it's well tolerated. Dose reductions and interruptions occur in most patients. But what you'll find when you use this combination is long-term durable remissions that we simply didn't see in the same proportion with platinum-based chemotherapy. I spent, with a number of colleagues around the world, we spent a decade trying to explore the optimal way of giving immune therapy in urothelial cancer with chemotherapy. And we struggled a little bit with a number of negative trials. Issue with platinum-based chemotherapy, specifically in advanced disease, is many patients develop acquired resistance quite quickly. And for many patients, immune therapy was not synergistic when given in combination with chemotherapy. There are many reasons why that might be the case in urothelial cancer and not in lung cancer, where we know chemotherapy and immune therapy in advanced disease is additive, and you do have positive or very strongly positive survival signals. We showed with platinum-based chemotherapy, particularly cisplatin-based chemotherapy, in the Niagara trial, in the muscle-invasive space, we do see a survival advantage, and with platinum-based chemotherapy and nivolumab in advanced disease, there's also a survival advantage. However, overall, much of this benefit is coming from sequencing these therapies rather than giving them concurrently. Enfortumab vedotin appears to have a different effect on the tumour microenvironment. It's likely, in my opinion, that the excluded phenotype that we see predominating in urothelial cancer is disrupted by enfortumab vedotin, more so potentially than with platinum-based chemotherapy. It may be that disruption is associated with a better immune infiltrate from the tumour microenvironment into the epithelial cancer. This is speculation, My feeling is spatial transcriptomics with sequential therapy, I hope, will unlock some of these unknowns. But it is fair to say that unlike the previous experiment, the combination of enfortumab vedotin with pembrolizumab, an immune checkpoint inhibitor, shows additivity. So we show a big bounce in response rates, up to 70% for the combination. We show 30% complete response rates that we simply haven't seen before with platinum-based chemotherapy and immune therapy. We also show these overall survival signals going into 3 years, where looking back in the past, the early immune therapy experiments, we were doing half that at about 17 months. And then when we look into muscle invasive disease and we look at other ADCs such as disitamab vedotin in combination with immune checkpoint inhibitor, we see path-CR rates of 60%. This tells us two things. Number one, the initial story with platinum chemotherapy, which didn't fulfill our ambition, can be overcome with the combination of enfortumab vedotin and pembrolizumab. But secondly, and importantly, these findings may not be exclusive to EV-Pembro. There may be other ADCs in which they work. And number three, as we move these drugs earlier into the disease setting, into muscle-invasive disease, it is my feeling we will cure a lot of bladder cancer patients with, or dare I say it, without cystectomy. One of the reasons I'm in your beautiful country, in China, in Beijing today, is to talk about adverse event management of enfortumab vedotin and pembrolizumab. As one travels the world from Canada to France, from the United States of America to Japan, and now China, this has become the transformative regime in urothelial cancer. In China, I'm aware that disitamab vedotin and other ADCs are widely used. And indeed, we know that these drugs are not given for a fixed number of cycles, but continue until progression of disease. And therefore, when one treats these patients, it should be looked at as more of a marathon than a sprint. Giving high-intensity toxic drugs at high toxic levels and treating through toxicity will turn out to be a mistake for your patient. And just like we learnt with VEGF TKI therapy in kidney cancer, drugs like sunitinib and axitinib, we needed treatment breaks and dose reductions to maintain the drug in the patient for periods of time. It's my experience that every patient's journey with EV and Pembro is different. It is my experience that at cycle 10, the vast majority of patients have not had every cycle at full dose at exactly the right time. It's my experience that skin rash during the early part of the therapy requires interruptions and dose reductions. It's also true that other adverse events such as transaminitis, fatigue, hyperglycemia, these events also require dose modification and adjustment. After cycle 6, and usually before cycle 12, peripheral neuropathy requires attention, and again, that's associated with dose interruption and dose reduction. It's fair to say that clinical experience and real-world evidence has a really important role to play in this. In my opinion, and in my team, we've learned how to give these drugs more effectively. We're now in a place at our institution where we're confident we can give these drugs without running into too many adverse events by dose interruptions and some dose reductions, and indeed some patients stopping drugs early and maintaining that durable response. And so what I encourage you today is to say that these drugs are transformative, number one. Number two is please do learn about the adverse event profiles, particularly the early toxicity and that later toxicity. Feel free, and indeed I encourage you to dose reduce, to dose interrupt, to make sure the toxicity goes back to baseline or near baseline before reintroduction. Because my experience has been long-term durable responses and patients tolerating therapy well. So This last question is a very exciting question, and it raises possibilities. I'm an optimist, and I've not always been an optimist in urothelial cancer. Indeed, if you go back 10 years to my talks, I don't know if you could find them, but they will tell you a story of frustration, challenges with biomarkers. We struggled with biomarker development. We now have that in urothelial cancer with HER2 and with FGFR and with ctDNA. So my frustration there has been overcome. I also had a frustration that we never could really beat platinum-based chemotherapy. We've done that soundly, comprehensively. And so my third frustration was cystectomy was a debilitating operation that we were performing in patients in their often 8th decade of life. Many patients never got their quality of life back after that operation. The Niagara study of perioperative durvalumab with platinum-based chemotherapy prior to cystectomy shows us immune checkpoint inhibition works better earlier in the disease with a significant survival advantage, a 10% bounce increase in path-CR and a significant delay in the time for the cancer to come back. But we also know EV Pembro has outperformed platinum-based chemotherapy significantly, and there are randomized trials, B15 is an example of that, of EV Pembro versus platinum-based chemotherapy in this setting. This is muscle-invasive disease, historically a 50% relapse and mortality rate, and it is my feeling that we will see positive data for EV Pembro in this setting relatively soon. And when we see this data, I think it will transform not just advanced disease, but perioperative disease. By having a high path-CR rate, I think it may be as high as 60%. We've seen 60% for DV Pembro, why not for EV Pembro in the randomized phase 3? And when this happens, that third goal of mine, biomarkers, replacing platinum chemotherapy, and preventing the need for cystectomy, I think we'll begin to achieve that goal, where patients will have EV Pembro neoadjuvantly, go into a clinical complete response with normal MRI, normal cystoscopy, not have cystectomy, and be followed up from there. That will be perhaps the last chapter of a long journey, but there'll be chapters after that, or new books after that, with new combinations of this second generation of ADCs, many of which China is leading the charge.